Treatment of a psychiatric disorders. The geriatric patient. The importance of diagnosis. Medical training introduces clinicians to the concept of a manual as a quick guide to diagnosis and treatment, best exemplified by the Merck Manual 1982. Here we find that a patient presenting with symptoms of somnolence, confusion, psychosis, stupation, and muscle weakness may have an elevated calcium level and need symptomatic treatment with hydration, low calcium intake, and physical activity, pending diagnosis of the etiology of the hypercalcemia. Another patient may present with altered consciousness, fever, and a stiff neck. Unless we consider the diagnosis of meningitis and get a lumbar puncture, we may fail to initiate appropriate life-saving antibiotic therapy. As we become more and more immersed in psychiatric practice, we encounter fewer and fewer examples of the kind described above, e.g., diseases that fit a 𝔎-𝔅𝔞𝔩𝔩 standard diagnostic and treatment format. Nonetheless, our panel has tried to bring, whenever possible, the Merck Manual orientation to DSM-3R, American Psychiatric Association 1987. We have tried to make clear that accurate diagnosis still remains the cornerstone of successful treatment, even though at our current state of knowledge there are organic mental syndromes for which symptomatic treatment is our only option. Indeed, in preparing this section, we have come to realize how limited is our knowledge and how vast our ignorance. Nevertheless, for all of the organic mental syndromes, as for all diseases in medicine, the search for underlying causes and accurate diagnosis remains of paramount importance. It is only when the psychiatrist's diagnostic acumen, augmented by modern medicine's technological resources, has been exhausted that it becomes appropriate to resort to symptomatic treatment. It is our hope that this section will aid in sharpening the psychiatrist's diagnostic skill in focusing on specific treatments where available, and in understanding symptomatic treatments for the organic mental syndromes. We want to point out that we have not been all-inclusive in our approach. To cite just 3 examples, we confine ourselves to adult patients only, see Section 5. We omitted special sections for the alcohol and drug-abusing patient, see Sections 12 and 13, and we limited our discussion of experimental treatments primarily to those for multi-infarct and Alzheimer-type dementias. We did include discussions of economical and legal considerations in treatment, topics that are assuming ever-increasing importance to our patients and their families as well as to society at large. Finally, we want to make clear that all of our contributors labored hard and revised their chapters on more than one occasion in an effort to provide the most accurate, up-to-date information. Nonetheless, we are well aware of the fact that perfection can be pursued but not attained, hence, your comments will assist us in improving the next edition. Indeed, it is our fervent hope that as the 20th century draws to a close, research in psychiatry will provide reliable markers to guide us through that vast and largely uncharted field that we subsume today under the designation of organic mental syndromes, so that much of what we have to say in the present section will have become obsolete by the time of the next edition. The geriatric patient, aging and organic mental syndromes. Substantial advances in the treatment of organic mental syndromes in older adults occurred only after the changes associated with normal aging were differentiated from the changes caused by disease in later life. The blurring of normal aging with illness had stalled progress in the clinical approach to the older patient, particularly in the area of cognitive functioning. When it is considered normal to display marked cognitive decrement, senility, with aging, clinical resignation, if not nihilism, is the response. Cognitive changes with aging. What does the literature reveal about normal cognitive function with aging? Owens 1966 reported on a longitudinal study of intellectual performance in 96 men, with an average age of 61 years, who had originally been tested in 1919 as freshmen at Iowa State University. The key finding of this study was that, on the average, there was little change in intellectual test scores as these men aged from 50 to 60 years. Previous report by Owens 1953 had shown increments in verbal ability and total score of intellectual performance as these men moved from age 20 to age 0. Yes, or although numerical ability showed a slight decline. These studies were among the first to raise serious doubts about the presumed normal decline in mental abilities with advancing age that had been inferred from earlier cross-sectional studies. In 1955, a 12-year longitudinal study of men, median age 71, was initiated at the National Institute of Mental Health, Granick and Patterson 1971. The goal of a study was to examine a broad range of variables in individuals of advanced age whom disease was absent or minimal, in an effort to differentiate the impact of AG versus that of illness. Of note in these healthy aging subjects, as they moved on the average from their 70s to their 80s, was that while various intellectual function declined, others improved. Speed in carrying out different operations, quality of draw a person, and quality of sentence completions declined. On the other hand, vocabulary and picture arrangement improved. In terms of everyday life, these findings suggest that certain activities requiring quick reactions or a high degree of precision might not be carried out as well by older adults in general, although the ability to understand one's situation and learn from new experiences is maintained in later life. Moreover, it was found that decrements in intellectual performance with advancing age were significantly greater in subjects who also developed arteriosclerotic cardiovascular disease than in subjects who remained healthy. The study illustrated the impact of illness on intellectual functioning with aging, while showing how intellectual functioning is maintained in aging individuals who remain healthy. Similar results were obtained in the only study of intellectual functioning in aging twins. This New York State Psychiatric Institute study also showed that a critical rate of decline on some subtests, vocabulary, similarities, and digit symbol substitution, of the Wechsler Adult Intelligence Scale, Wechsler 1944, could be used as a predictor of mortality, Arvik and Bank 1983. Since then, the terminal drop hypothesis has been controversial. On balance, however, the hypothesis that certain intellectual declines relate to a foreshortened lifespan has held up. Orientation toward treatment. Even when clinical changes in the elderly are viewed as potential signals of underlying illness, too often there is a delay in seeking treatment. This phenomenon is an example of the general obstacle of differentiating disease in older adults from changes associated with aging per se. Prompt treatment is all the more important in the elderly, given the greater potential in the frail geriatric patient for physical damage or deterioration with acute episodes of illness. Acute changes, in fact, are often not even recognized as being acute in the older person. Consider the development of disorientation to time and place in a given individual. If the individual is 32 years old, such symptoms will likely elicit alarm and immediate action. If the individual is 82 years old, such symptoms may elicit dismay and reflection about the person's age. How often, however, do family members or physicians ask themselves whether this 82-year-old ever showed disorientation before? Might this be the first episode, and could it be signaling a hypertensive crisis that could lead to stroke and permanent organic mental syndrome unless treated immediately? The course of illness with aging. A fundamental clinical aspect that distinguishes the older from the young patient is the greater likelihood of the former having more than one illness and receiving more than one treatment concurrently. Thus one must pay greater attention to illness interactions along with treatment interactions, e.g. polypharmacy issues, in geriatric patients with organic mental syndromes. Cohen 1985. The aggravation of the course of an organic mental syndrome in the older patient due to the interplay of these factors. Inadequate recognition of how disorders can be brought into remission through the life cycle also has an impact on treatment of the geriatric patient. If an illness areas up in a younger patient, the hope, if not the expectation, is that remission can achieved. In the older patient, however, the predictable expectation is that the course will be downhill as a phenomenon of aging instead of as a phenomenon or the illness. Hence, even though a disease process is recognized, negative stereotype about the elderly can prevent the use of standard clinical approaches that should be employed independent of the patient's age. Related to an inadequate understanding of the course of illness in later life is poor recognition of the potential role of rehabilitation for the geriatric patient. 𝔎-𝔅𝔞𝔩𝔩𝔦 If an organic mental syndrome is of a non-progressive nature or exhibits extended periods of cynical plateaus, the opportunity exists for some level of rehabilitation. Service utilization, service delivery, and financing issues. For many years the scientific literature has been pointing to the problems of low mental health service utilization and delivery for older patients. Reddick and Taub 1980. While those aged 65 and older represent 11% of the population, less than 5% of patients seen at public and private outpatient mental health facilities are in this older age group. Again, many explanations have been offered to explain this pattern. Cohen 1976. On the utilization end, difficulties in physical mobility, poor transportation, fear of crime, low income, and stigma issues have been described as among the factors affecting the behavior of older adults in seeking out mental health services. On the delivery end, negative stereotypes of the elderly, inadequate training in geriatric mental health, and poor reimbursement provisions on the part of private and public insurance programs have been portrayed as factors affecting the behavior of the mental health care delivery system in providing services for older patients. Meanwhile, progress is occurring along all these fronts. Cohen 1980. Reimbursement change for Alzheimer's disease and related disorders. It was in the fall of 1984 that a specific group of organic mental syndromes in the aged led to what had been regarded as the most important change in Medicare coverage for mental disorders since the inception of Medicare over 20 years ago. Goldman et al. 1985. In September of that year, a major task force report on Alzheimer's disease was released by the U.S. Department of Health and Human Services 1984. Within the report there was a special financing recommendation was announced as being implemented in conjunction with the release of the report. The purpose of the recommendation was to remove limitations on services for Alzheimer's disease and related disorders provided outside the hospital setting. Magnificently, the recommendation read as follows. Current Medicare statute limits medically appropriate physician services provided out of the hospital setting for patients with Alzheimer's disease when coded as a med disorder. The department should clarify that, except for psychotherapy, physician treat to the $250 limitations. In other words, in determining whether services for these patients meant services for patients with Alzheimer's disease and related disorders are not subject to the limit, the nature of the physician's service is the deciding factor or the diagnostic code. Therefore, physician treatment services provided outside the hospital 3 and ICD-9 should be reimbursed in the same manner as services for Alzheimer's setting for patients with Alzheimer's disease and related disorders coded 290. X in DSM. Disease coded 331, 1 CD9 pages XV. The intent of this administrative change was to correct an inconsistency by which reimbursement for the same service differed depending on which diagnostic code for treatment of Alzheimer's disease was used. 290. X versus 331, although both codes referred to Alzheimer's disease and related disorders. The intent, to zero, was to reimburse for office visits for the medical management of Alzheimer's disease, in ordering pharmacotherapy and other non-psychotherapy treatment interventions, and 80/20 reimbursement copayment formula, as opposed to the dollar limit and 50/50 reimbursement copayment formula that still holds for psychotherapy. This change should substantially improve the ability of those patients suffering from the organic mental syndrome of Alzheimer's disease or a related disorder to seek state-of-the-art clinical interventions. The social situation of the older adult. The interplay of social factors with biomedical and psychological variables is particularly prominent with geriatric patients, Palmore 1980, and is most apparent with persons of an advanced age over 85, referred to as the old, in whom the risk of an organic mental syndrome is greatest. Management of clinical problems among the frail in this age group is considerably complicated by the social phenomenon that the children of these patients are themselves likely to be senior citizens. In addition, older women have an even more difficult situation because they are much more likely to be without a spouse to help them manage their health problems. By age 65, 50% of women who had been married are widowed, by age 75, 70%. This social situation of lacking a helping spouse, coupled with females living longer than males, largely explains why most of the residents in nursing homes are women. U.S. Department of Health, Education, and Welfare 1978. Within the community, availability of informal support systems to assist in the management of illness in those of an advanced age, and in those with organic mental syndromes in particular, is a growing dilemma as the age group 85 years and older toward increasing sevenfold in numbers between the years 1980 and 2050 from 2.2 to 16 million. U.S. Senate 1984. The need for help with basic activities becomes a consideration for many people at this stage of the life cycle. In managing illness in this age group, one must constantly pay close attention to changes in the older person's social situation, especially those that result in a thinning of the support system. For example, 1 in 7 men aged 65 years and older live alone, whereas 1 in 3 women in this age group live by themselves, and how long the geriatric patient with an organic mental syndrome can remain in the social support network thus becomes a key factor in determining how well the community still, too often, dispositions for the older patient are decided in narrow dichotomous terms, i.e., home versus nursing home. The fact is that there are many options in between, such as the utilization of homemaker, respite, and/or daycare to their families. Part of the challenge to skill and creativity in geriatric management programs that can help keep these elderly individuals in the community and closeness dealing with these complex biopsychosocial variables. The geriatric patient with an organic mental syndrome represents no exception to this challenge and opportunity.